gradual ventricular dilatation and lead to post-traumatic hydrocephalus. I will share some case example in my setting. This 6-year kid who presented to us with an acute subdural hematoma. He has undergone decompressive. We admitted in a GCS of E1, B1, M4, and at discharge he was E4, B2, M5. We discharged in patient in this status. After 3 months, he attended OPD with this large bulge at connecting side, with significant improvement in neurological status. Only he had right upper limb monoparesis at that time, OPD visit. On CT scan, we can see gross dilatation of both ventricle, more on ipsilateral side, less on contralateral side, with a diffuse brain gliosis or edema, with bulge of brain coming out of the connecting side. So these we can confuse these in the background of improved neurological status. The child has no feature of rage ICP. So we avoided any CSF divergence procedure at this patient. We simply tapped this ventricle and underwent for cranioplasty, which I think has cranioplasty has reversed the pathophysiology which was going on, and child did well in the post-op follow-up without any CSF divergent procedure. And this is another case, 29-year-old female, which taught lots of lesson about post-traumatic hydrocephalus. So similar patient, acute SDS, decompressive connectomy was done. Patient was discharged, admitted at M2, discharged at M5. At follow-up, we can see the follow-ups we can see when presented with wound bulge on at connectomy side, but diffuse bulge was there. We can see intrahemispheric hygroma, contralateral subdural hygroma, marked effect. So this thinking about what we can do for this patient, we have first went for subdural peritoneal surgery. I think in the follow-up, I think it was our ignorance about post-traumatic hydrocephalus. To reduce that, thinking that reducing this hygroma can solve this problem, and later on this patient can do cranioplasty. But situation worsened, hydrocephalus increased. As you know, these are the contralateral subdural hygroma, intrahemispheric hygroma, always are forerunner for post-traumatic hydrocephalus. Hydrocephalus bound to develop whenever these phenomena on CT scan. But on the reverse, what we had did, this we had meningitis, maybe that shunt, subdural peritoneal shunt got infected. We removed shunt, patient undergone antibiotic treatment, and with similar wound bulge, there was no deterioration in sensorium. Later on, this patient also undergone ventricular trapping, simple and cranioplasty. And after that, patient didn't require any ventricular peritoneal shunt or CSF divergent procedure for this ventricular megaliohydrocephalus. Similar patient, decompressive connectomy, temporal hematoma, resolved. You can see large balloon operative site, ventricular megaly, but with intrahemispheric hematoma. This patient also had deterioration sensorium. So similar approach was fine, but this time we have did this patient with simultaneous VP shunt and cranioplasty, and patient did well. So this is the another spectrum of post-traumatic hydrocephalus. Another patient, 37, male patient, he had outside operated, undergone craniotomy, similar hospital, come to us with 6 months follow-up with features of NPH. And this patient, post-traumatic hydrocephalus, can present as a feature of NPH. We evaluated this patient, undergone VP shunt, straightforward case, patient improved. And this is the third spectrum of patient of post-traumatic hydrocephalus we can see in the patient of TBI. This patient, we can see operate most patient with bifrontal contusion with a decompressive connectomy. In my feature, these patients, in my experience, develop post-traumatic hydrocephalus more frequently than other patients. This patient also similar approach we have found, because there was no deterioration sensorium, simple ventricular trapping and mass cranioplasty, and solve the problem without any CSF divergence procedure, and patient did well. Still in our follow-up. So what are the risk factors for post-traumatic hydrocephalus? First and foremost is increased severity of primary brain injury, decompressive connectomy, and delayed cranioplasty, and intrahemispheric hygroma and contralateral hygroma on the CT scan. These are risk factors. for post-traumatic hydrocephalus, which is discussed in the literature. In this paper, they have shown GCSI admission, duration of coma, Fisher grade, decompressive connectomy, and subdural hygroma after decompressive connectomy, extra connectomy herniation of brain. All these are from decompressive connectomy. All they have found their risk factor for post-traumatic hydrocephalus in the follow-up. So for decompressive connectomy, we have as we discussed, what are the factors we should consider during decompression? We should always remove a bone of more than 2.5 centimeter on midline. Connectomy should not expose superior sagittal sinus, or should not have at least 2.4 centimeter bone at superior sagittal sinus. Connectomy extending more than 3 to 5 centimeter posterior coronal suture, intermesmic hygroma, and contralateral subdural hygroma. All these are features are associated with post-traumatic hydrocephalus in the cases of decompressive connectomy. And the similar pathophysiology have been discussed as we discussed. The longer the time we to take in cranioplasty, more is the changes in the CSF pressure and dynamics in the brain, and more chances to develop post-traumatic hydrocephalus. And literature have ample paper on regarding early and late cranioplasty to develop the to prevent post-traumatic hydrocephalus. In our setting, we usually do it at 3 months. Whenever the brain edema settles, patient is able to undergo second surgery. So early cranioplasty may help, and these asymptomatic, both asymptomatic ventricular dilatation or post-traumatic hydrocephalus patient. So early cranioplasty may prevent and decrease the morbidity of the patient. And various papers also discuss how we do simultaneous cranioplasty of the patient, or we should do in this stage manner. But in this paper, they have discussed that simultaneous cranioplasty of patient may have higher complication in it and should be avoided. But I have not found any conclusion in my practice on definitely conclusion to how we go about it. This is a similar paper of how we do treatment strategy for this patient for post-traumatic hydrocephalus, or in cases of ventriculomegaly or post-traumatic hydrocephalus. They have found simple ventricular drainage, extraventricular drainage may found the improvement or non-improvement. If patient improving, we can go for CSF diversion. Non-improving, we just go for the conservative policy or simple cranioplasty in these patients. So the treatment strategy is not very clear in cases of different people are suggesting different things. So in this paper, they have discussed about extraventricular drainage to find out symptomatic and non-symptomatic cases, and a role of programmable shunt in the cases of failed BP shunt, and have been discussed in various paper. Still, I don't have much experience on VP shunt, programmable VP shunt for these patients. So VP shunt is a treatment of choice in our setting. We do usually Chabla shunt for these patients, and very less explanation of programmable shunt for these post-traumatic hydrocephalus. And in literature, they have suggested the given the shunt revision rate about 70 to 25%. These are the questions we have already discussed. How we go about it: cranioplasty and shunt, simultaneous or interval, shunt on same side, contralateral side, and a role of programmable shunt. So literature is not very clear about this. And another thing about to discuss about endoscopy third ventricular ostomy in the cases of post-traumatic hydrocephalus. What is the role of these minimally invasive procedures? And literature what I have gone through have found it is beneficially only in the cases of complicated cases of post-traumatic hydrocephalus where VP shunt has infected or failed. So in some cases, it can be used as a salvage procedure for post-traumatic hydrocephalus. And another thing, what we are discussing in most of trauma meeting nowadays about basal cystostomy, as various our STEAM faculty always discuss, because by doing basal cystostomy, we can put back the bone and decrease the morbidity. But this thing to be discussed on, to look upon how we can do it. Because if you are putting bone back, maybe we are preventing these complications in the post-op follow-up by reducing the cases of hydrocephalus or ventromegaly in these patients. So our approach is simple, is ventriculomegaly, we should just observe, and we do cranioplasty in ventricular tapping. In the cases of there is no feature of resuscitation. In post-traumatic hydrocephalus, we do VP shunt and CSA divergent plus minus interval cranioplasty. So take home message is post-traumatic hydrocephalus occur in significant proportion of patients in TBI, and it can lead to an unfavorable outcome. Post-traumatic hydrocephalus has to be distinguished from asymptomatic ventriculomegaly as early as possible. Because otherwise, many patients may undergo the CSA diversion unnecessary. In my what I think, the judicious use of decompressive craniectomy, we should not remove bone in every case. We can put back whenever it is possible. Timely cranioplasty may prevent post-traumatic hydrocephalus. Thank you.
Thank you, Dr. Thank you, Dr. Kamlesh.
This is from my side. Thank you.
Thank you, Dr. Kamlesh. I will request.
We can see the basilar artery. Once this
can you listen to me?
Created, we angulate our scope.
Can you listen to
massa intermediate?
Yes, sir. We can hear.
And we reach the tumor. Here you can
okay,
see.
Okay. Thank you, Dr. Kamlesh, for this very interesting topic, and it's a very difficult topic. Let me tell you. And I have seen myself and everybody faltering with ventriculomegaly and hydrocephalus. And as you rightly pointed out, it's very difficult sometimes to differentiate. You have to really go through the clinical status of the patient, understand the changes in the clinical status. And it's very common for everybody to just make a mistake of putting a shunt in a patient of ventriculomegaly instead of hydrocephalus. So you have dwelt on this topic very well. And the only issue is that when there is decompressive craniotomy, the volume loss, and the hydrocephalus makes the ventriculomegaly makes the whole clinical picture very complicated. So I think you have covered the topic very well. So we can request for any questions to be discussed in this case. The main issue is the pressure. What is the ventricular pressure in this case? And I personally would feel that we would first do a cranioplasty if there is a wide decompressive craniotomy done. That actually establishes the pressure in the ventricle, and then put the shunt in the next sitting or in the same sitting after the cranioplasty, because then you actually know what is the actual pressure inside the ventricle, and then decide about the type of shunt to be put, whether you want to put a programmable shunt or a low pressure shunt. Sometimes you need a low in these patients because of the volume loss and the brain compliance change. So any questions, please, can be answered in this session. Very interesting topic and very important topic, I would say, and very, very common problem.
But the problem of
Dr. Deepak Agarwal, any questions?
Thank you. Thank you, sir.
Yes. Thank you, Kamlesh, for that excellent talk. Only thing I think I can add from my side, because we face the same problems, we're managing so many traumatic brain injuries, and decompressive craniectomy is an integral part of neurosurgery. What we see also is subdural effusion with interhemispheric infusion. And there is a specific entity which is defined in literature that if you see an interhemispheric effusion along with ventriculomegaly, you should not consider it to be a simple ventriculomegaly. That means there is hydrocephalus. And we had written a paper long time back, around 10 years back on this, and we had reviewed the literature also. And in these patients, wherever you see interhemispheric subdural effusion, these patients will not settle with anything like a lumbar or subdural lumbar drainage or anything like that. They will require a VP shunt. And with a VP shunt only, because a lot of people are confused what we should, there is a subdural effusion also and there is ventriculomegaly. So people get confused and do not do anything, which is a wrong thing. All these patients require a ventriculoperitoneal shunt. We have proven it many times, but still people are not aware. So I think you have brought this out very nicely that if there is a subdural effusion, it does not mean that pressure is low. In fact, it is the opposite in especially in traumatic brain injury. So it's a completely different entity. Literature is very sparse and an excellent topic. Thank you.
Thank you. Sir, we have seen similar experiences in our practice also. Whenever we see contralateral subdural hygroma or anti-hemispheric hygroma in a post-op scan, so we should have raised the alarm because it's vision is going to land up in a post-traumatic hydrocephalus.
Correct. Thank you.
Thank you very much, sir. As we do not have any question, so I would like to request next speaker, Dr. Colonel Suvir Day, for post-traumatic CSF rhinorrhea.
Yeah, good evening to all the members, and it's a privilege to be here on the platform. I hope the slides are on.
Yeah, it's there. When it starts.
Yeah. So today the topic is given to me is about the post-traumatic CSF rhinorrhea. It's a very common topic, and day-to-day practice, it leads to a lot of mishaps, a lot of infection, a lot of abscess, and later goes on to the refractory epilepsy also. Most commonly seen in India, and India being the world's capital for the road traffic accident. And it happens only when there is a breach or a dehiscence of the arachnoid, dura, or a bone. And predominantly seen in the road traffic accidents. But nowadays, it is the skull-based surgery that's leading more common cause of the CSF leak. But this topic is more of post-traumatic, so we'll concentrate on the post-traumatic CSF leak. Most important is to identify it and give a diagnosis to prevent the potential infection, abscess, or any refractory seizures or even death. The literature which says, it was a literature around 2004, it's published in the Journal of Neurosurgery. It says the cause of meningitis, the rate is around 20%. It's quite high. And if we compare it with the Indian, in fact, we don't have any data how much is the incidence rate of any post-traumatic meningitis, but this is a cause of concern. But the days, if we go back, the first and second century, it was the CSF leak was seen in following a cranial trauma in second century. Later, it was correlated by a skull-based fracture by a Dutch surgeon. Later, it was confirmed in 1913 that CSF leak is predominantly is due to pneumocele rather. And in 1923, the first emphasis was given on the closure of the CSF fistula. Later, there was more rapid things that came up with Dandy giving intradural techniques, then Cranes giving a classification on the CSF rhinorrhea and extradural repair. Schroeder gave a resolution that lumbar drain may be useful. In fact, today also some people are using the lumbar drain for the CSF leaks. Doman gave on the extracranial repair, and the Vigand, which is now very important, is the endoscopic repair of the CSF leak. Now, coming to the stats, the most common cause of any CSF leak is trauma. It is seen around 80% of all the cases in and predominantly it is seen in the sphenoid sinus, which is around 30%, and frontal sinus is around also 30%. And non-traumatic is only 16%, rest 4% is on spontaneous leaks. This is the data of relatively old, around 2002 article, which was a Western-based literature article, which showed that these incidences like this. And of these trauma leaks, were predominantly seen more than 50% in first 2 days and 70% within first week and delayed maybe around 3 months of it. Omaya and McCoy has classified the CSF rhinorrhea into two. One is the traumatic and non-traumatic or spontaneous. The traumatic is mainly acute or delayed, and non-traumatic, which is not the part of the discussion today. So we'll not focus on this, the right side of the screen. So mainly intracranial sites is either in the anterocranial fossa or the middle or the posterior. The sites of exist may be in the nose or in the eye, which is very uncommon, but it is there, or in the nose or ear. The commonest site which is seen is due to the anterior cranial fossa defect. It is mostly common in the cribriform plate ethmoid cells. In my experience, what I have seen is the most commonly seen is in the cribriform fracture, which is very commonly seen. And Sakas has also classified the anterior cranial fossa defect into involvement of the cranial cribriform plate. Type 2 is the medial portion of the anterior skull base involving the frontal or the ethmoids. Type 3 is the lateral frontal. And type 4 is the combination of all. Most important is we should come to a diagnosis by a bedside. It is very profusely seen in a case of if there is a profuse leak. The most challenging thing comes when there is a mild low flow leaks. If it's a clear fluid that's coming on bending the head, if there is a clear fluid from one of the nostrils, and there is a postnasal drip or a salty sensation that is there, which is aggravated on coughing, which may be associated with the CSF leak, or it may be associated with anosmia or periorbital hematoma, or there may be optic nerve or dysfunctions. The bedside test, what's available and what is very important nowadays is the handkerchief test or the halo sign, the double target sign, which is seen with the CSF going away from the blood, or the oxidized glucose of more than 30 mg per deciliter. The beta 2 transferrin is very highly sensitive, very expensive, and not done in our scenario. There are others tests like glucose and chlorine concentration being also tested for this. There's an article which says the usefulness of the glucose detection in diagnosing CSF leak and the use of CT and beta 2 transferrin. The sensitivity of beta 2 transferrin is very good, and however, the glucose is not recommended as a confirmatory test. So according to timing, it is divided into early leaks, delayed, or very delayed. Early, we normally say it's less than 7 days, or it is 7 days to some months, or if it is more than months or years, it's very delayed. The early leak, one should be less than 7 days. The primary concern is of main of the brain injury per se. And normally it is seen, and the literature also supports that it normally stops by around 85% by 1 week. And diagnosis is relatively easy if it's profuse leak is there. However, the challenge comes when it is mild leak and there is no clear fluid coming from the nose. And the management remains a conservative in these kind of cases. Only worrisome is about the infections. There are various articles which shows that what is the percentage of, as late as in 2023, an article said that the risk of meningitis has come down. Earlier in 2004, they said that the risk of meningitis is quite high as 20%, but now they say the risk is very low. So should we give antibiotics? Do we have a class 1 evidence or recommendations? Unfortunately, we don't have any level 1 recommendation on this. However, level 2 recommendation says that perioperative antibiotics significantly decrease the postoperative infection rate in a case of facial fractures. What has come to in new practice is the pneumococcal vaccination that is given in basilar skull fractures. That is being practiced and it is being given as the recommended level 3 evidence. Then other use is the use of acetazolamide. There's an article by the PGI Chandigarh which says that acetazolamide does not influence the resolution of traumatic CSF. However, there is an article in American Journal of Otolaryngology which says it is showing promising thing that acetazolamide does help in decreasing the CSF. So we have both the pros and cons of use of acetazolamide in a case of conservative. Next is the use of any lumbar drain. There is an article in Clinical Neurology and Neurosurgery which says that initial use of lumbar drains in a case of CSF resulted in significant decrease in the leakage of the CSF. So in our practice, we are not recommending any use of acetazolamide or use of any lumbar drain. And how do we diagnose? Initial days were use of the X-ray skull was there where we could see any pneumocephalus. Later in the pre-set CT, we used to see the radioisotope scintigraphy. Now what is important is the HRCT of demonstration of any defect in the bone and its correlation with the MRI. This is now what is the standard of investigation that is in our institute. We are following it. And now MR cysternography shows a definitive leak in these cases, and which has got a sensitivity and specificity of around 95%. There is another imaging that's coming up is the 4D MR cysternography, which captures the dynamic CSF flows. There's an article from the Hyderabad Institute of Medical Science, which says that beta-2 transferrin, they have followed up with the beta-2 transferrin positive cases. Then they correlate with the HRCT of the skull bone. Then they divide it into 3 categories. If defect is visible, no defect, or multiple defects. Based on that, they have delineated when to go for the MRI scan, when to go for the endoscopic scan, and whether to go for the radionuclide cystogram. So this is the article that is being followed. They said that the MRI cysternography is quite specific and sensitive for finding the CSF leak. Another article from Chennai, which showed that they compared the beta-2 transferrin overlapping with the MR cysternography. The MR cysternography, they said it's sensitive around 89%. When they combined both the techniques, it becomes like sensitive to around 95 to 97%. So various articles which has been shown in this, which has showed that combination of HRCT and MR cysternography has got a sensitivity of 93%, and specificity has come down to 61%. Another thing that's coming up is localization of intrathecal fluorescein, the use of CSF tracers, the fluorescein, the radioactive immunoassay, the iridium technetium labeled albumin are all being used to find out where the defect is. The management remains as a conservative in a case of early leaks or a surgical, especially in a case of penetrating injury, a large pneumatocele, or a brain herniation with the signs of meningitis, or in a case of post-surgery. Normally, it is seen in our practice that a CSF leak by conservative, it stops by around 10 days. Prickly of Italy has classified the anterior cranial fossa into 3 types based on the frontal sinus. These frontal sinus are very notorious. They normally don't close by the conservative. So he has advised that any frontobasal involving the posterior part of the frontal sinus has to be addressed and has to undergo surgery as early as possible. So timing of surgery is again a debatable topic, whether to go an early or delayed surgery. Delayed surgery, normally we have got the recommendation that if there is failure of conservative of more than 10 days, or there is recurrent pneumatocele, or there is evidence of any meningitis. The most important thing that is there is whether to do endoscopic or transcranial approaches. The literature is very recent, as in July 25 this year, which shows that endoscopic repairs demonstrate a superior safety profile than an open surgery. Another article in 2000 from the laryngoscope, which shows that endoscopic repair is highly effective, immaterial of the site, size, and the defect. So there is a systemic meta-analysis also in 2022, which showed that endoscopy is better than the open surgery with lower complication rates and lower hospital stay. The principles of any endoscopic surgery is first is the identification of the leak, expose and delineate the defect, create a raw area around the defect, and plug the defect with the fat and cover it with fascia or with tissue glue. The exposures are the standard 4 approaches: medial or the transethmoid for the lateral cribriform, transmaxillary or the transpterygoids for the lateral sphenoids, or transethmoids for the posterior or posterior thirds of the cribriform plates. The material what we use are either the fat or the fascia lata, pedicle flap or the mucosous flap, or the bone and or the fibrin glue. The type of repair can be overlay, inlay, the plugs, or bone use of the bone and cartilage. There's various articles and various outcomes have been divided. However, it is on the surgeon's discretion, the overlay versus inlay, overlay versus the plug, and the use of bone or the cartilage. This is a small video of we have a cribriform plate defect where a CT showed a bone defect, and later he was evaluated by the CT and the MRI cyst images which showed a leak, the CSF leak at the right side of this. That's the part of the meningeal breach. So he was exposed to the endoscopic. First, we take the middle turbinate as the repair material and remove the medial part of the mucosa, and of the middle turbinates, and delineate the bone, and coming to the lateral part of the middle turbinate also. Later is the identification of the leak which is there. Then we found that there is a profuse CSF leak from the cribriform plate. Next is the dissection of the defect and delineating the defect and making a raw surface of that area so that our repair is adhered to that. As the dissection being done around the defect. Now, after removing this, we can see the defect and the CSF leak will be visualized with surrounding areas. And first, we plugged it with the abdominal flat. Fat is kept as an onlay repair, which is reinforced by the parts of the middle turbinate bone and further reinforced by the tissue glue and covered up with the mucosal flap. Later, over the mucosal flap, hemostatic agents are kept and the nasal pack is being given. The advantage of doing any endoscopy is that it gives a better cosmetic results, decrease the hospital stay, and anatomy is not altered. However, there are certain disadvantages. It looks like it's an unphysiological because we are approaching the repair from below. And always the debate is there, should be the size where we should not address it endoscopically. Secondly, the posterior part of the frontal sinus is difficult for doing an endoscopic repair. In that cases, another approach is doing a transcranial, which can be a intradural or extradural. Extradural is mainly done for the fracture of the posterior wall of the frontal sinus. It is a standard supine position with extension of the head, bifrontal craniotomy, exposure of the pericranium, and then it is placed over the sinus and cranialization of the frontal sinus is done. What we follow is the multi-layered graft reconstruction. That placement of the graft, fibrin glue, as well as a gel foam or a Surgicel, which is very effective in this case. In these settings, the minimally invasive is also not very far away. Our colleague, Dr. Sinha, is also doing endoscopic transcranial, where a small craniotomy and exposure of that defect is being repaired by the fat of the facial lata is being done. And in Germany also, transorbital surgery is being carried out. So these are not far where minimally invasive can take on the transcranial or endoscopic. Post-operatively, they are given bed rest for 3 days and the pack is removed after 3 days. Injectable antibiotics with decongestant and stool softener is given. We normally ask the patient to avoid 3 C's. That's constipation, cough, and coitus. So the take-home message is CSF leak is a challenging thing, especially in case of low flow status. Various new imaging modalities are available and used to diagnose very slow flow leaks, and biometric materials which may help in the facilitate the repair of the CSF. Second, the thing is it's all surgeons' expertise that is required and the team effort, which is very important to help in the diagnose and treat these patients. Thank you so much.
Thank you very much. Thank you very much, Dr. Subir Dey. This was an excellent exposition of the total profile of CSF rhinorrhea. As you rightly pointed out, 85 to 90% of the CSF leaks should stop. The issues of using acetazolamide and lumbar drain in an acute setting can be problematic because if there's a severe head injury, you're giving acetazolamide, you're producing acidosis, which might complicate the situation so far as the metabolic changes in the body is concerned in a polytrauma patient. And you have to be very careful with lactate and other factors which might jeopardize the recovery of the patient and the biochemical issues. Lumbar drain in acute head injury where there's brain swelling might be a risk. So juniors must understand that. At the same time, though endoscopic repair is now a fashion, but in case of acute trauma, you can have multiple fractures in the base of the skull, specifically if there's associated craniofacial injury. And many times with a depressed fracture in the frontal region, which is going up to the frontal sinus, you might have to straight away go for a surgery to elevate the fracture and remove contused brain. And in that situation, you can as well do a repair of the anterior cranial fossa floor from the top. And that becomes more physiological because you have done both the things in the same setting. So it's a wide subject and very much variable to the associated trauma in the craniofacial region, which also plays an important role in this particular management. And you have covered it extremely well. If there are any other questions, please. Dr. Deepak Agarwal might like to comment something as well. Please, Dr. Deepak.
Thank you, sir. I think what Dr. Sudhir has presented is quite well, and I would agree with Dr. Pathak that although endoscopy may be favored by surgeons, it is better to err on more conservative side, especially in acute cases where patient is admitted and we need to give him or her time for that 90% leak subsidence spontaneously to happen. A lot of times surgeons rush in to operate where just being conservative might save the day. So because these are complex injuries, it is very rare that they have a very small defect. A lot of time the whole skull base is fractured, and I think it's only in a very select cases is really a repair required. We at our own trauma center, um, we hardly do couple of cases a year because most of the cases recover spontaneously, and I think that would be the experience of others also.
Sir, Partha sir raised a question about the uses of Diamox. So are you using Diamox in acute setting in any case?
Not at all. Not at all.
So, Deepak sir, hello.
Yes, we use Dymox very routinely. As soon as we detect a leak, the first thing we start is Dymox with plus minus lumbar drain, and it it remains to be, that is our training, and I think most of the patient, it might happen they're spontaneously subsiding the CSF leak, but even if it helps 1 or 2%, why not give that chance to the patient?
Yes, sir. In Nimans also we use Diamox that once the leak is there with plus minus number than what you told. So, and what you told, almost 80 to 90% cases leak subside. Very rarely is required surgery.
The issue is 80 to 90% will subside spontaneously also. So there's no, a controlled study to really prove or
Yeah, that
disprove
that
whether
that
the.
that 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 is
In
agreed.
fact,
There is no controlled
sir,
study.
And secondly,
Yeah,
the
so
antibiotics also, I never use any antibiotics just for the CSF leak. What I do is that it might be a controversial topic. I take a nasal swab in all these cases. And of course, after working in National Health Service UK some 15 years ago now, routinely I advocate the pneumocephalus vaccine to the especially children, yes. And then we take it from there. We have a culture report, and if there is a meningitis, then we know what sort of organism might have gone in, and we use the antibiotics judiciously in that. We think that we use the antibiotics judiciously in that form. So that's the way I do it. It might be different with others.
no,
Sir,
agree, sir.
sir,
That same thing I wanted to ask. Like, what is the role of perioperative antibiotics?
Perioperative,
For potential for bacterial resistance. That's very important.
if there's CSF leak, no, don't start antibiotics as such.
Yeah.
Yes. If there is surgery, of course, then you might need to give antibiotics because you have exposed to
Perioperative.
contaminated
Yeah,
field.
yes, right.
in fact, what I
how
have
do we
seen that
further?
patients who has presented with some leak and they have stopped spontaneously within 7 days or so, but after 1 year or so, they have come back with CSF leak.
Yeah, that's why that was my question. How do we follow this patient? Do we have any requirement of MR cystoscopy or CT cystoscopy? So we are the patient which we have managed conservatively. So sometimes
Yes,
these
there.
patients come with meningitis.
In fact, there is a study and literature which shows that we have to follow up these patients for at least 3 years.
So how
And
will we
once
follow
you,
annual imaging or no? Actually, these are two different things. Like giving post-operative, not post-operative. Like in that period, patient is having CSF rhinorrhea and giving antibiotic. That is a different thing. And post-traumatic CSF rhinorrhea that can happen even after 20 years or 30 years after post-traumatic. If I remember correctly, the longest that history, I think 30 or 35 years. That patient presented that in literature. Here in Niman's one case report, we reported 25 years after trauma. Patient presented with CSF rhinorrhea. So that can happen. We cannot do anything for that.
These are different cases. Here, actually, what is happening is that there was a breach which got temporarily sort of sealed off. And now with time, when the brain has regained its normal texture and for any other reason the pressure has got elevated, you can have a leak as a delayed leak, like something like a delayed spontaneous CSF rhinorrhea, even in the non-traumatic variety, they might be having a hole, but they start leaking once the ICP gets raised for any reasons. So that's really a different group of patients altogether.
What is written in human is that if there is encephalocele in MRI and subsequent, they follow compliance, then it needs to be repaired. If there is only one evidence of CSF, and follow-up MRI, if there is encephalocele, you have to repair.
Hello.
Can we move on to the next talk now? If there are no questions, please.
Yeah, the next topic is one more controversial topic, very interesting topic. I'll invite Dr. Surya to present the post-traumatic epilepsy and seizure. Dr. Surya, you can share your, your screen is visible.
Good evening. I thank the team from NTSI and the moderators for giving me the opportunity to talk on this topic. So after wonderful presentation by my co-speakers on hydrocephalus and CSF rhinorrhea, which can lead to seizure and epilepsy, and we are all aware that sometimes it can be challenging to treat patients with seizures and epilepsy. So I shall be before proceeding on to post-traumatic seizures. This is a point which everyone should note, that post-traumatic seizures is not equivalent to post-traumatic epilepsy. So coming to the so because for it to be defined as epilepsy as proposed by ILE, these seizures should be unprovoked. It can either be two unprovoked seizures which are more than 24 hours apart, or one unprovoked seizure and the probability of future seizures similar to the previous condition, or if there is a diagnosis of an epilepsy syndrome. So coming to the classification of post-traumatic seizures, it can be classified as immediate when the seizures occurs less than 24 hours following traumatic brain injury, early when it is within 1 week of injury, and late when it is more than 1 week after the injury. The important point to be noted here is immediate and early seizures, they do not increase the risk of seizures later. However, late seizures, they increase the incidence of late seizures and can be considered as epilepsy. The seizure types which are seen after traumatic brain injury are all the types described by ILE. And to describe about early post-traumatic seizures, they have an incidence of around 4 to 25% of cases, and it is seen till 7 days of injury. It is more common in children and patients with severe head injury, and the risk factors for early post-traumatic seizures being diffuse cerebral edema, a retained metal fragment, patients with residual neurological deficit, or patients with depressed or linear fractures. Now I would bring bring to your notice regarding this landmark study by Anagas et al., where they studied civilian head injuries in population over a period of 50 years and followed up over 10 years. And they found that patients with mild head injury and moderate head injury, the cumulative probability of 5-year seizures is almost equivalent as general population. However, the probability of seizures at 5 years in severe head injury is much more than general incidence, that is 10%. And this is denoted by the relative risk, where there is 17 times more risk of having delayed seizures in patients with severe head injury. This article was published in 1998, where they defined the severity of head injury based on the following criteria. Mild was defined as loss of consciousness or amnesia less than 30 minutes with no skull fractures, whereas moderate was defined as LOC or amnesia where it lasted between 30 minutes to 1 day, and when there was presence of skull fracture. Whenever there was presence of brain contusion or intracerebral hematoma, or the amnesia lasted 24 hours, it was described as severe traumatic brain injury. They had described that for the first time, they described that early seizures, they do not confer increased risk of late seizures. and the specific risk factors for late seizures being acute subdural hematoma, presence of intracellular contusion, presence of linear fracture in a patient aged more than 5 years, presence of depressed fracture in any age group, and if the loss of consciousness or amnesia lasts more than 24 hours. Patients with early seizures or older age group or linear fractures in pediatric patients less than 5 years do not increase the risk of late post-traumatic seizures. This graph describes the probability of seizures in following brain injury. This line denotes that, denoted by the square symbols, which depicts the probability of seizures after severe head injury. As you can see, the probability of seizure is much more than following mild and moderate. And the important point to be noted here is the patients with severe head injury can have recurrent seizures even after a long latent period of 10 years after traumatic brain injury. This table depicts the incident rate of seizures when in different severity of head injury after following the interval following injury. In mild injury, the risk of late seizures, they typically subside completely by 4 years. And the rate of incidence of seizures following mild injury is almost comparable to the general population without head injury. But in case of severe head injury, about 50% of seizures occurred in the first year. And the risk of seizures following head injury remained elevated even after 10 years after the primary insult. A similar study published from our institute studied on patients with various head injuries. We found out that the incidence of late seizures was around 2.7%. And on univariate analysis, you can see that as depicted in the yellow font, these are the various factors which had a risk factor for post-traumatic seizures. That is female gender, fall from height, delayed loss of consciousness, patients with pre-existing medical problems, or with severe head injury. However, in multivariate analysis, patients with who had a mechanism of fall from height, who had an pre-existing medical problems, or patients with severe head injury, these patients had an increased risk of post-traumatic seizures. And the Kaplan-Meier graph depicts the impact of post-traumatic seizure on survival in these patients. So coming to the role of the controversial topic, that is anti-seizure medications. This was one of the initial studies in 1983 where they studied the role of carbamazepine in severe head injury, where they compared carbamazepine with placebo, and they found out that carbamazepine is better than placebo in reducing early seizures, that is less than 1 week. However, there is no difference in late seizures between those two groups. A similar study for phenytoin, where they did a randomized double-blind study in 404 patients, where the phenytoin levels was maintained in the high therapeutic range, and patients were followed up for 2 years. They found out that phenytoin has leads to decreased incidence of early seizures compared to placebo. So the findings remain similar. So this is a graph depicting the incidence of seizures in patients who are taking phenytoin compared to placebo. That is till day 7. Similarly, there were studies on valproate, where the effects of valproate was similar in early post-traumatic seizures, but it had no effect on decreasing the incidence of late post-traumatic seizures. There were various studies on role of steroids. However, categorically, there is no role of steroids in treating seizures. Around 15 to 20 years back, there were numerous publications which stated that levetiracetam is superior to phenytoin. However, that was debunked by the Cochrane review, where they had analyzed 10 RCTs, which concluded that there is only low quality evidence that anti-seizure medication is has a better control of early seizures when compared to placebo. I would like to state again, it's a low quality evidence. However, there is no evidence to prescribe anti-seizure medications for reduction of risk of late seizures or mortality. And they also stated that there is insufficient evidence to make any conclusion to prefer one antiepileptic over another, that is levetiracetam over phenytoin. And the same was reflected in the guidelines for management of severe traumatic brain injury, where they said that prophylactic use of anti-epileptic medication is not recommended for preventing late post-traumatic seizures. And phenytoin is recommended only to decrease the incidence of early post-traumatic seizures. And there is insufficient evidence to recommend levetiracetam over phenytoin for early post-traumatic seizures. So this is a level 2A evidence in adults. The same holds true in pediatric traumatic brain injury patients, where it's a level 3 evidence, where they have proposed anti-seizure medication only for early post-traumatic seizures. So after that controversial topic on anti-seizure medications for early seizures, coming on to post-traumatic epilepsy, it accounts for about 5 to 9% of all epilepsies, and it is seen after 1 week after traumatic brain injury. And as depicted in the graph earlier, the latency can be years, sometimes even more than 10 years. And it is the most common among the secondary epilepsy. And it has a spectrum of all types, and we are all aware of the impact of post-traumatic epilepsy. Now, coming to risk factors specific for post-traumatic epilepsy, patients with severe traumatic brain injury, they have a higher incidence of post-traumatic epilepsy, and the latency varies. Patients with penetrating trauma have much more incidence of post-traumatic epilepsy when compared to closed head trauma, and especially when there are retained metallic fragments compared to other simple fragments. And the specific type of injury which leads to increased incidence of post-traumatic epilepsy is depressed fractures, subdural hematomas, contusion, any previous craniotomy for traumatic brain injury, and LOC more than 30 minutes or amnesia, and patients with a fixed focal neurological deficit. Coming to the location of injury, injury which is located in the frontal and temporal region has a higher incidence of post-traumatic epilepsy. And patients with pre-existing medical conditions like alcoholism or even patients with depression, they have been found to have higher incidence of post-traumatic epilepsy. Presence of a pre-existing family history is a risk factor in case of children. However, it is not a risk factor in adults. And there are certain genetic factors which like ApoE4, which has been identified in post-traumatic epilepsy. Coming to treatment of anti-seizure medication for post-traumatic epilepsy, even after 1998 publication, there are no clear-cut guidelines regarding what is to be prescribed and for how long it has to be prescribed. And there is also unclear criteria regarding when the medication should be stopped and how it has to be tapered. So currently we are sticking on to the guidelines prescribed for patients with non-traumatic epilepsy. That is, the medications are usually tapered after 2 years of seizure freedom. Is there a role of resective surgery in post-traumatic epilepsy? About 1/3 of patients with post-traumatic epilepsy have drug refractory epilepsy. That is, the seizures which are not controlled for 2 years with at least 2 anti-seizure medications given in appropriate doses, either alone or in combination. The pre-surgical workup remains same, that is epileptic protocol MRI with a video EEG. And in case of discordant cases, we may proceed on to SPECT or a magnetoencephalogram. After a good working hypothesis, it has been found that patients who have undergone temporal lobe resection in patients with post-traumatic epilepsy, the seizure-free outcome is similar to patients without epilepsy without head injury. And So as in patients without post-traumatic epilepsy, the seizure freedom is 40 to 50% in frontal lobe resective surgeries. Coming to role of neuromodulation, the indications hold true as in patients with non-traumatic epilepsy, that is seizure if it is localized bilaterally, if multiple regions of the brain are involved, or if the localization is to the eloquent cortex. And numerous studies have described that VNS or deep brain stimulation, the results are similar to patients with non-post-traumatic epilepsy. We must all be aware how to deal with something which is very important, that is status epilepticus. When the seizure activity lasts for more than 5 minutes, and if it lasts more than 30 minutes, it can have long-term consequences. So the initial stabilization phase holds true, that is stabilization of ABC. And important point to be noted here is to look for hypoglycemia. And in adults, to give thiamine before infusing glucose. The benzodiazepines remain the drug of choice in the initial management of first-line management of status epilepticus. And if this is not controlled, we may proceed on to intravenous levetiracetam, valproic acid, or phenobarbital. And if all this doesn't control the seizures, we proceed on to thiopentol or skeletal muscle relaxants with EEG monitoring. This is a flowchart which describes the management of patients with moderate and severe TBI. If a patient with a patient with moderate and severe TBI is given anti-seizure prophylaxis for 7 days. So if the patient does not have any seizure after 7 days, the anti-seizure medication should ideally be stopped. However, if patient has seizures more than 1 week after traumatic brain injury, the patient should be continued on anti-seizure medications. The duration and which medication to be given and how it has to be tapered, there is a gray area in the literature regarding this. Even in spite of anti-seizure medications, if the seizures continue, that is in 1/3 of the patients, they are classified as drug refractory post-traumatic epilepsy. Then we evaluate them and identify if they can be candidate for resection surgery or palliative surgery. So to conclude, I would like to state that post-traumatic seizure is not equivalent as post-traumatic epilepsy. It is important to differentiate between immediate and early seizures, which occurs within 7 days of injury, compared to late post-traumatic seizures. And early post-traumatic seizures, they do not increase incidence of late post-traumatic seizures. And prophylactic anti-seizure medication, as per literature, has to be continued only for 1 week, and it has no role in decreasing incidence of late post-traumatic seizures. Although our practice has significantly changed towards the use of levetiracetam, there is no significant difference between phenytoin and levetiracetam for prophylaxis. We must all be aware of the significant latency period in post-traumatic epilepsy, and the management remains same as in patients with non-trauma epilepsy. And so this is a gray area where there are no clear-cut guidelines for choice, duration, or stopping anti-seizure medications. Thank you.
Thank you once again, Dr. Surya. Very nice presentation, very difficult topic and very controversial. And it's a routine. Everybody would put a patient on anti-epileptics, whether they need or don't need. A couple of things I just want to point out. Infants are very prone to seizures. Even if they mild head injury, which is short lasting, a brief period of, some sort of stunned attitude after head injury, they would throw a fit. So any infant who has got a trauma should be observed very carefully. The parent should be made aware that the child still can have seizure even if the child is normal. So they don't have much consequence as to continue as in the form of chronic seizures, but they tend to have fits very easily in the within few hours of the trauma. So that's number one. The other thing, of course, if the post traumatic scars are very difficult to manage, and surgery also is not very optimal in these situations. The gliosis I'm talking about, gliotic changes after trauma, is another very difficult, and these patients tend to be on antiepileptics for long and need multiple drugs. And I don't think surgery has got a very good answer for them in these situations. With this, I request any other comments from any of the audience, please.
Surya, I would just like to say that you have done an extensive and excellent review of the literature, and maybe you should write up a review article on this so that all that effort which you have put in for this webinar does not go waste. And please put it, and I would request all webinar committees, whatever the presenters put, at least in the NTSI journal. Now, Dr. Vivek is the editor, but these can be published easily. All these topics are excellent. The people have worked so hard in reviewing the literature, and the manuscript is just a week's job for all three of the speakers today.
Thanks.
Absolutely, absolutely. I echo what Dr. Deepak Agarwal is saying. I think you cannot have a much anything better than what we discussed today. In just 1 hour, we really have been covering 3 very important topics and controversial topics. And this has been again a revision or re-revision, as you say, and we are still not clear in many aspects. There are a lot of shady areas still there. But I think if you just jot down the same thing in a expanded form, it will be a beautiful article to publish. I echo what Dr. Deepak Agarwal is just mentioned right now. Any
Sure, sir.
questions?
We will
Yeah.
discuss on this, sir.
Right. Yeah. So any questions for anybody to sort of ask?
So, Dr. Surya, what practice you follow for prescribing anti-epileptics in DEMS for severe TBI without any evidence of any seizure?
The current practice is to prescribe anti-seizure medications for around 6 months, although the practice may vary among the consultants. And for mild TBI, we specifically stop the anti-seizure medication after 2 weeks.
So for severe TBI, you are giving it for 6 months.
If the patient does not have any episode of seizure. If the patient has an episode of seizure, so we start tapering the dose of anti-seizure medication only after 1 year, after the last episode of seizure.
I understand, then you follow the protocol of seizure.
Yes.
Tapering after 2 years. But without any evidence of seizure,
the practice is still to continue with months. Yes.
The question is what we call as evidence of seizure in a patient who is deeply unconscious and on ventilator. Now there is something called a subclinical seizure. So in this situation, everybody would try to err on the extreme side of trying to be safe by putting the patients on anti-epileptics in at least initially for 2-3 months till the patient becomes conscious. To ward away any untoward effect of subclinical seizures which is going on, which won't be picked up clinically, which won't be manifested sometimes in EEG in a very severe head injury patient. And in the periphery, specifically outside the institutes, these sorts of patients, everybody would try to play safe. And that becomes an issue. And all these patients have a lot of metabolic disturbances, hemodynamic disturbances. So one doesn't know what's going on. And the physiology is very difficult to understand in a patient who is unconscious and just being ventilated with a little bit of sedation. So that becomes a controversial issue and a difficult issue for anybody. And we have to play safe medico-legally also, because a seizure can mar whatever improvement you are getting on the patient in the initial period of your treatment. So that always remains a debatable issue, and I mean, in our setting at least, we have to always save our skin. So that's number one. Number two, we are not understanding what is happening in a peripheral center. there's no proper monitoring also in some places, yet the patients are not that financially good enough to go to travel a long distance to reach a higher center sometimes, and the patient might be quite sick also to be transferred. So there are a lot of issues in our country, in our setting. And so people, what I see, prophylactically want to give antiepileptics. And then even if the patient is shifted, the next clinician continues that. Whether the indication or not, that becomes the issue, but you are at least playing safe.
Yes.
I think Dr. Ved Prakash Maurya is trying to ask some question. Can you ask Dr. Ved?
Hello, good evening, sir.
Yeah. Carry on.
All the three topics are very interesting, sir, and have been duly discussed. I asked, sir, regarding this second post-traumatic CSF rhinorrhea, what is the policy of doing CSF rhinorrhea repair, means ACF-based repair, to Dr. Sudhir Day? How long they wait for conservative management, and whether do endoscopic repair or transcranial repair? What is the guideline and what is the practice they are doing it in the center?
Sir, what we are following is if there is profuse leak and the GCS is low, severe head injury, we normally go in for the operative with ACF base repair in upfront only. We don't wait. If he's a severe
Transcranial, you mean?
transcranially,
Okay.
and if there is CSF leak is there and it's like mild head injury, can be observed for 3-4 days, and normally it stops by around 4 to 5 days, and then if not stopped, then 5 days we normally take a cutoff, and then we go for endoscopic for a mild low flow leaks.
Okay, sir. Over the period of these 5 days, do you put the patient on Dimox, some Dimox medication?
We do put on Dimox and strict bed rest and stool softeners also.
And what about lumbar drain insertion?
Lumbar drain I have not put. We normally don't put.
Okay, sir. So suppose I have a patient who met with a closed head injury, supraorbital fracture, inner table got fractured, and there is hemosinus and adjacent contusion, and patient has an episode of CSF rhinorrhea after a period of 1 day. So what is your protocol for such patients, sir?
If GCS is okay,
patient is intact, not having any underlying significant.
I would like to observe him for at least 5 days, and then if the CSF doesn't stop, then we would like to go for it. If it's a posterior wall of the frontal sinus, then I will go for cranial surgery only, transcranial.
Okay, sir. Okay. Thank you, sir. Thank you so much. Can I ask one more question, sir?
As many as you want.
Thank you so much, sir. So second question to Dr. Surya. Obviously, it was a very nice topic and very extensively researched. Dr. Surya, means for patient having post-traumatic patient of TBI not presenting with any episode of seizure, whether mild, moderate, severe. So what is your protocol? You are giving antiepileptic or not? And if yes, which antiepileptic preferably?
Thank you, Dr. Ved. I would like to state that although the evidence points otherwise, our clinical practice is different. The evidence states that for early seizures, prophylactic anti-seizure medication is to be prescribed for 7 days. But yes, that is the only available evidence. That too, it's a level 2 evidence. But the current practice which we follow is we give anti-seizure medication for 2 weeks in mild TBI, and in moderate to severe TBI without history of seizure, we give for a period of around 3 to 6 months.
Okay. So at our center, we are having an ICMR funded project, which our center is a spoke of the multicentric study going from primary center is AIMS Jodhpur. So our center is a center chosen for that multicentric trial where we are doing a randomized control trial where medication is not given to the patient until the patient throws seizures. So we are expecting some good outcome from that trial. At least no such trial has been conducted ever in our country. I think that will give some clue to the topic. Thank you very much for the nice presentation and the discussion.
So, Dr. Anil, are you there?
I'll request Subhash sir for closing remarks. Sir, one question is there. Is there any role of EEG before stopping? Dr. Surya, can you answer?
So
Is there
some
any role of
studies, yes.
EEG before stopping the anti-seizure medication?
So some studies have proposed that even after there is no clinical seizure, before starting the tapering of the dose of anti-seizure medication, some studies have proposed the use of EEG, but that is not the standard practice.
Thank you.
So can I answer that? Actually, if you see a seizure activity, that is helpful. But if you don't see a seizure activity in the EEG, that doesn't mean that the person doesn't run the risk of having a seizure after stopping the anti-epileptic medication.
Yes.
So because the EEG that we routinely do is, just a simple ordinary channel EEGs, it's not really representing the undersurface of the frontal lobe and the deeper part of the temporal lobe and other areas. So if you see a seizure activity, no question, the anti-epileptics cannot be withdrawn. But if you don't see a seizure activity and you're tapering off, you better warn the patients. This has happened in my practice regularly, and not once, at several times. I can't remember how many times. I routinely do an EEG to rule out any upfront seizure activity. If it is not there, I still warn the patient that we are tapering, we are slowly tapering. In a month's time, each dose comes down, or sometimes couple of months. And then I warn them that you still have a 5% chance of having seizures in compared to the general population, which is quoted in the literature. And if you have the seizures, this is what you're supposed to do. Straight away, you would take initial care of not having aspiration and then rush to a local center and start your medication with the loading dose. And you can even speak to me on phone and I'll guide the physician there. Normal EEG doesn't rule out that you won't have a seizure. But if there's a upfront change in the EEG, you are not going to stop the antiepileptics. That's the way I would sort of behave.
Thank you very much, sir. There are many questions.
Yes, I know. This is you have chosen all the three controversial topics in one day, which is you can have a mountain of questions now.
I'll request Senna sir for closing.
So, thank you very much. And for a wonderful webinar, needless to say, this was beautifully crafted and mainly led by Dr. Deepak Singh and Dr. Anil. And I really congratulate them for doing this part of their work. And NTSI has, as we discussed in the last meeting in Goa, now been starting the webinars. Now this will be a monthly basis, and we are trying to get webinar CME credit hours for each webinar also. So soon we are coming up with the full schedule of the list of the webinars for at least 6 months or 1 year, and then uploading on the website with the CME credit hours, because you have to apply for the CME credit hours well in advance.
Yes,
It is in the process, and we'll soon let the NTSI members know about it, and would request everyone to to participate in large numbers. I was surprised and happy to see that at the middle, there was somewhere about 40 plus attendees joining and hearing the webinar. So thank you very much. Thank you both the panelists, Professor Ashish Pathak and Professor Deepak, for their kind presence and their wonderful inputs for carrying out this webinar and discussions, and the moderators also. And looking forward for future wonderful academics at NTSI. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, sir. Good night, sir.
Thank you, sir. Good night, everyone. Thank you very much.
Thank you
very much. As there are no questions, we are closing this webinar.
Sure.
Thank you.